until relatively recently, we've really had an established frontline treatment with FOLFIRINOX and gemcitabine nab-paclitaxel. As we've discussed, we now have a second-line regimen that has received FDA approval with liposomal irinotecan and fluorouracil. Alternative options in that setting might be oxaliplatin-based therapy with 5-FU. So increasingly for patients who receive gemcitabine-based treatment up front, they'll be candidates for 5-FU-based therapy as a second line, and it's certainly logical to consider gemcitabine nab-paclitaxel, then liposomal irinotecan, and then potentially for those that are eligible and well enough, oxaliplatin-based therapy as a third line. So that's an example of how thinking has evolved based on the availability of regimens and based on the ability to think about sequencing in terms of treatment choices. For patients, in contrast, who receive fluoropyrimidine-based therapy up front, so for example, as a frontline treatment for metastatic disease, receive FOLFIRINOX, and it's logical to consider gemcitabine-based treatment as a second line. There we don't have a lot of data suggesting whether that should be a single agent or a combination. We certainly have data suggesting that using both of these active regimens in sequence contributes to the totality of improvement in outcomes. And that's a discussion point these days. How can we maximize disease control and longevity and minimize toxicity, and what's the best way to do that as our choices become more in this disease? And I think we're beginning to address some of those questions in the clinic, but we still have a lot to learn in terms of what's the optimal strategy. And I would say choices are good, and we're happy to have the availability of regimens and not necessarily be wedded to the fact that one combination and sequence is better than another.